Hello, this is Dr. Henrietta Bada, and I am the Director of the Division of Maternal and Child Health of the Department for Public Health, and also a Professor of Pediatrics at the University of Kentucky. Today, I'm going to talk to you about neonatal abstinence syndrome and the associated multiple risk with the condition. For disclosure, I received an honorarium as a member of the advisory board meeting for the US World Meds. Now, what are our educational needs and practice gap? The major practice gap is the lack of integration and coordination of the care for infants with neonatal abstinence syndrome and their mothers and family. Our educational need is to understand the risks associated with neonatal abstinence syndrome at all levels in a socio-ecological framework. Upon completion of this educational activity, you will be able to cite the epidemiology of neonatal abstinence syndrome, or currently being called neonatal opioid withdrawal syndrome, or NOWS, to be able to understand the extent or magnitude of the problem, to list the various risks associated with neonatal abstinence syndrome, or NOWS, which can affect outcomes, and to list the protective factors that will mitigate risk and enhance outcome. From this offering, the increased awareness of risks associated with NAS will guide us in any prevention or intervention effort. The problem of opioid use goes back several centuries. The one who does not remember history is bound to live through it again. As a historical background, in 4000 BC, the Sumerians migrated from Persia and settled between the Tigris and the Euphrates rivers. They discovered a plant that will eventually bring more pleasure and more suffering than any plant in history, the plant of joy, or opium. Opium grows in different types of climates and soil and resistant to insects and fungi. The gum from opium seed pod contains morphine, codeine, alpha narcotic papaverine, and thevenin. In the 16th century, Paracelsus created the concoction laudanum from the Latin word laudare, to be praised, opium mixed with brandy. Physicians use laudanum for coughs, diarrhea, dysentery, and gout. In 1800s, Louisa May Alcott and George Washington used liquid opium. Mary Todd Lincoln was addicted to it. Isolation of morphine and expansion to medical use also occurred in the 1800s, and morphine was marketed by Merck and Company for pain relief and alcohol treatment, and morphine also became an intravenous drug. Two opium wars between Britain and China occurred. China lost both times, resulting in China ceding Hong Kong to the British. In 1875 was the first reported case of a newborn with signs of opioid withdrawal at birth. The diagnosis then was made as congenital morphism, no treatment, and the infant died. In late 1800s, Dresser developed heroin, or diacetyl morphine. It had a high potency, so that they thought it would be, one would need less dose, and of course they thought it would be associated with less risk for addiction. In 1947, methadone was approved for use in the US. 1966, buprenorphine was discovered. This is what we call Subutex right now, and FDA approved in 1985. In 1975, Finnegan published the Neonatal Abstinence Syndrome Scoring System, and 6 months later, Lipsitz published the Neonatal Drug Withdrawal Scoring System. In 1986, Portnoy published that opioid maintenance therapy can be safe, salutary, and more humane alternative for patients with intractable, non-malignant pain and no history of drug abuse. He believed that compassion for patients with terminal cancer be extended to all patients, and this was based on experience on 38 patients. Therefore, we had the birth of pain as the fifth vital sign. Drugs like oxycodone had finally solved the problem of pain relief when it was marketed, and it was marketed as a drug that will not result in addiction. In 1997 was the first reported case of buprenorphine withdrawal in newborns, and in 2002, the first reported case of OxyContin withdrawal in newborns. And that newborn was actually from Kentucky. Our big concern is that there are 128 in the US die each day from an opioid-related overdose. And this was a report in 2018. With the opioid epidemic crisis, deaths from overdose, there's also an increase in NAS or NOWS cases. And with that, the increase in hospital costs. But what happens to these children after they leave the hospital or after discharge from the nursery? In Kentucky, this is the number of cases reported since 2001 to 2019. Notice that in 2001, there were only 46 cases with a diagnosis of NAS in Kentucky. And then in 2015, we had a peak of 1,354 cases. And we were sort of, in a way, glad that in 2018, the number dropped to 907. But recently, we have an increase to 1102 in 2019. So this is the rate of NAS, meaning the number of cases per 1,000 live births. And in 2001, it was less than 1 per 1,000. And then it increased to 24.3 per 1,000 in 2015, and then dropped to 20.4 per 1,000 in 2017, and decreasing in 2018. But it's back up to 20.9 per 1,000 in 2019. In 2019, we have 1,102 infants reported in our NAS registry, and 65% with polysubstance exposure, and that is excluding tobacco and alcohol. If we look at these cases, what we find is that the mothers are either very young, less than 20 years of age, or between 25 and 29 years of age. They're primarily white and with a high percentage with less than high school education. Also, with almost half of these mothers with NAS in the rural areas, and then 92.7% on Medicaid or self-pay. 11% are born late preterm, and a third of them are requiring NICU admissions. Notice too that smoking is very high among mothers who have NAS babies, 73.3% versus only 17.1% among mothers with babies with no NAS. Hepatitis C is on the rise. It is as high as 35% among mothers with using drugs, and these babies with NAS are exposed to hepatitis C in 34% of mothers who are positive, and only 1.7% of those babies with no NAS. The most common substance used is really buprenorphine, that is your Subutex, and also Suboxone, 67%, and other opiates, 40%. Heroin is 21% among those in the registry, methadone, 10.5%, marijuana or cannabinoids, 26%, benzos, 11%, cocaine is much lower, 7.8%, and gabapentin or Neurontin in 5.35%. Gabapentin use is increasing and is being used in combination with opioids. The drugs which produce neonatal withdrawal or neonatal abstinence are usually the opioids, but they can have NAS if they are withdrawing from alcohol, barbiturates, or caffeine. And the other drug that is commonly resulting in NAS is the selective serotonin reuptake inhibitors. We call them SSRI. That means Prozac, Paxil, Celexa, Zoloft. And then we have the other tricyclic antidepressants and also benzodiazepine like Valium and drugs like Benadryl, Atarax, Miltown, Equinil. They can also be associated with neonatal abstinence syndrome. New in the landscape, especially in Kentucky, are the leaves from the tropical tree kratom in Southeast Asia, which causes stimulant and sedative effects in different doses. More commonly abused in Asia Pacific region than the United States, but we're seeing cases of abuse of kratom here in Kentucky. They're a derivative of the Mitragyna speciosa, or a coffee plant family. There are two main alkaloids, and the potent one is the 7-hydroxymitragynine, which has a higher potency than morphine. This drug will not appear in the urine toxicology. It is used for pain, anxiety, depression, or to stop or reduce withdrawal symptoms, and is being used as an opioid substitute. It does cause neonatal abstinence syndrome. Deaths are reported among those who are using kratom, 11 reported between 2011 and 2017, and an increase to 44 in 2017 alone. And deaths are usually from the combination of using kratom with other drugs, but there are also deaths from just pure kratom use. Now, is this legal or illegal? In Kentucky, it is not illegal, okay? The other states that has kratom as illegal are Alabama, Arkansas, some cities in Illinois, Indiana, New Hampshire, Franklin City, in Tennessee, especially in those less than 21 years of age, and its use in pregnancy, and if used with other medications. And then Vermont, Wisconsin, and it has been a controlled substance since 2014. Now, what are the signs of neonatal withdrawal? I'm not going to go into details on this, but just recall that there are central nervous system signs from high-pitched cry or decreased sleeping time, hyperactivity, and tremors. There's also GI disturbances, poor feeding, regurgitation, loose to watery stools, and metabolic vasomotor disturbances like sweating, fever, sneezing, yawning, mottling, and respiratory difficulty, primarily nasal stuffiness and really tachypnea, rapid breathing. And retractions we see much less than tachypnea. And then fever is also noted in these babies. So how do we treat them? We treat them with non-pharmacologic management, reduce noise in the environment, dim light, swaddling, rocking, massage, occupational therapy, physical therapy, speech therapy, and music therapy. But the best thing also is to provide optimal nutrition through breastfeeding for mothers who are in compliance with their treatment programs. We can use formula, and usually they end up requiring high density or higher calories, and also appropriate head position when they're feeding these babies, because they have some disorganized sucking and swallow movements. And then if they do not respond to non-pharmacological treatment, then we treat them with morphine or clonidine or methadone or buprenorphine, and either as a single drug or with an adjunct drug like phenobarbital. There are several associated conditions with neonatal abstinence syndrome. Let's start with birth. That means some of these babies are born preterm. They have intrauterine growth restriction, so they're born very small. They may have congenital malformations. They may have medical complications such as aspiration, respiratory distress to the point that they may need NICU care, and sometimes even severe respiratory failure that they may end up on ECMO. They, of course, may need pharmacotherapy. That means with morphine primarily or other drugs. And the main issue is that some of these babies are going to need prolonged hospitalization because of treatment. Sometimes 3 weeks, sometimes 1 month, sometimes even two months. And of course, an associated measure of outcome for these kids is how long are they treated and how long do they stay in the hospital. However, I find that we have too much emphasis on the length of hospital stay. What are we missing if we just emphasize length of hospital stay? And where are the gaps when it comes to looking at the outcomes of these babies with neonatal abstinence syndrome? We do our best for regarding discharge planning. When the baby is admitted to the nursery, we report to the Department of Community-Based Services because we have to look into the home situation. Is it safe for this baby to go home with a mom, or should there be an alternative placement at discharge? We also look at the maternal characteristics such as her drug dependence, her mother's treatment, comorbidities. It's not really unusual that we have a high incidence of depression among these mothers. And what are her other medical conditions? And we do discharge teaching about safe sleep, about shaken baby, the routine well baby care, and coping with a difficult child. Then we look into the discharge disposition. Is the baby going home with mother, to kinship care, foster care, to adoptive family, or maybe to an institution? But this is done in conjunction with the hospital personnel, the baby's provider in the hospital, and also the worker at the DCBS. Then we arrange for follow-up care, the baby's medical home, and for developmental monitoring. And most importantly, all these activities should revolve around providing a plan of safe care for these babies. Remember that even if we give an appointment to a mom for the baby's follow-up after discharge, there's still a high chance that the mother will not comply with that appointment, and we will lose the baby to follow-up. And similarly, the mother will change addresses so many times in a week, and even DCBS will not be able to track down where the mother is and where the baby is. Now, what happens to these infants when they go home? One thing that we worry about is infant mortality, death within the first year of life. When we look at the leading causes of infant mortality in the US, we have congenital malformations as number one. Number two would be diseases related to low birth weight or prematurity. And then number three, conditions affected by maternal and pregnancy complications. And number four is sudden unexpected infant death. That's number four. If we look at Kentucky's infant mortality, the number one are diseases related to prematurity and low birth weight. And number two is sudden unexpected deaths or SUID. And congenital malformations only ranks number three. So what is bothersome is the high prevalence of sudden unexpected deaths in Kentucky. If we look at the course of, or the trend of sudden unexpected death, which is a combination of sudden infant death and death from unknown causes, accidental suffocation, and strangulation in bed, we see that the combined SUID rate has decreased in the 90s to late or early 2000, primarily because of a decrease in sudden infant death syndrome and because of the recommendation of the American Academy of Pediatrics of Back to Sleep campaign. However, after In the early 2000s, we see an increase of the combined SUID rate, while the sudden infant death syndrome is decreasing. And this is primarily due to death from unknown causes and accidental suffocation and strangulation in bed. The incidence in the United States currently is 92.6 per 100,000 births. In Kentucky, we have an incidence of over 180 per 100,000 births, which is really an alarming increase or alarming um, high rate of SUID in Kentucky. So if we look at the SUID rates by area development districts of residents here in Kentucky, on the left of your screen, you can see that the dark pink areas have the highest rate of SUID. And if we look at the rate of NAS by area development districts, you can see that you have the similar high rates of NAS in the southeastern part of Kentucky. In fact, if our rate in 2019 is 20.9 per 1,000 live births, in some areas like Kentucky River, the rate is 55.7 per 1,000 live births. Big Sandy has 42.35 and FIVCO 40.26 per 1,000 live births. So you can actually superimpose the high SUID rates areas with the areas with high NAS rates. Then if we look at the causes or the risk factors for SUID in Kentucky, notice the gray bars that 90 or over 90% of cases will have at least one unsafe sleep factor, whether the infant is in soft beddings and with hazards in the bed, the surface is not designed for infant sleep, sharing of sleep surface, and then the sleep position, the baby is on the side or on prone. And 1 out of 3 cases of SUID has a risk factor of either the baby had NAS, the mother is using drugs, or someone in the home is using drugs. So if we want to really decrease infant mortality, one of the intervention we have to do is to promote safe sleep among babies, not only those babies with no NAS, but specifically babies with neonatal abstinence syndrome or this associated drug use in the home. When we look at the data from the child fatalities and near fatalities external review panel, we notice too that maltreatment occurs in close to 50% of these cases reviewed, from physical abuse, neglect, or impaired caregiver. And if we look at the risk factors in these fatalities and near fatalities, in over 50%, substance abuse, domestic violence, and mental illness are the risk factors. Now, where do we see these factors? We see these factors in families affected by substance use. So with the key findings from the external review panel of child near fatalities and fatalities, substance abuse is the most common risk factors. The other factors are substance abuse, but not only by a caregiver, mental health issues, substance abuse in the home, prior criminal history, family violence, and prior history with Child Protective Services. So if the children survive or have been and not subjects of near fatalities in the early years of life, what other outcomes do we have to look at? But we must remember that there's complexity in the assessment of outcomes because cumulative risk will influence outcomes from just prenatal drug exposure, the family level influences, and the issues at the community level. So we look into the child's adverse childhood experiences, and they may be exposure to psychological experience, physical abuse, sexual abuse, domestic violence, living with household members with who are using substances, mental illness or suicidal experiences in the family, or involvement with the criminal justice system. And with cumulative ACEs, there's an increased association with risk of um, poor health, mental health, and early death as an adult. So in Kentucky in 2018, these are the prevalence of different adverse childhood experiences experienced by those 18 years old and older when they were asked about their childhood experiences. And notice that physical abuse in 15.8%, witnessed domestic violence in almost 20%, and the same thing, mental illness in a household member in 20%. Verbal abuse, 25.9%, drinking, about the same prevalence, and separation, divorce, parent, 33%. And when it comes to high number of ACEs, 5 or more among Kentuckians, age 18 and older, we have 12.5% among females versus 10.4% among males, but you have at least 10% among white, African American, those multiracial, and very high percentage among Hispanics. So among Kentuckians with 5 or more ACEs, they're almost 5 times as likely to have depression, 4 times as likely to have poor mental health, 4 times as likely to be a current smoker, 2.5 times as likely to be a binge drinker, twice as likely to have diabetes, and twice as likely to have poor physical health. So if we look at the prevalence of smoking, for example, which is the blue bars, notice that it increases with the number of ACEs from 15.5% among those with 0 ACE or no adverse childhood experiences reported to as high as 80.8% with those who have experienced 9 adverse childhood experiences. Similarly, depression among Kentuckians, 12.8% if they reported no adverse childhood experiences, but then when there are 5, this is up to 37.2%, and if there are 9 ACEs experience, 76%. So the risk factors, behaviors underlying these adult diseases are actually coping mechanisms. What is viewed as a problem by the healthcare provider is actually a solution to bad experiences for the patient. Dismissing these coping mechanisms as bad habits or self-destructive behavior misses their source of origin. So when we look at the adverse childhood experiences leading to early death, there's probably something that we can do if we know that adverse childhood experiences, actually, this is the bottom of the pyramid, the color pyramid, leads to social, emotional, and cognitive impairment through a disruption in neurodevelopment. So that we have to address the neurodevelopment of these children early on. So if we stay away from that pyramid, which are all adverse experiences, showing adverse experiences and what adverse experiences can lead to, let us look at the socio-ecological framework. You have here the child on your left, you have the family surrounding the child, then the neighborhood surrounding the child and the family, and with that we have also government or policies that is going to affect the child, the family, and the community. But with that, there are some risk factors, your adverse childhood experiences, but there are also protective factors that we have to direct our attention to. So in this slide, which is very busy, I just want to direct your attention more to the risk and the protective factors that the child and the family are going to see. And the risk, of course, the prenatal drug exposure, the substance use, and in the family, we look at the ACEs, the domestic violence, mental illness, adverse home environment, but look at the protective factors. If a healthy preconceptional health and pregnancy, prenatal care, well child that's born because of healthy pregnancy, the child's temperament, and when there's involvement of the family and the caretaker, we look into the caretaker child attachment. There's got to be support for that child, and there's got to be a good home. So those are the factors that can actually would be able to mitigate some of the risk factors that the children would be exposed to, especially those with neonatal abstinence syndrome. So this is an interesting slide, and it basically tells you what the environment can do and how the environment can influence genetics. In rats, the mothers are said to have good moms if they have the high licking or grooming behavior, as is shown in this slide. And if you cross foster the rat pups born to the mothers with high licking, uh, rather, if you cross foster the rats pups with born to mothers with low licking behavior, okay, then cross foster them to a mom with high licking behavior, those pups actually will develop the high licking behavior when they get older and become the rat moms. So this can be transmitted to the next generation. So if we start early in promoting attachment, then we would be able to at least impact or change the risk factors surrounding a child born with neonatal abstinence syndrome. So it is important that we promote the child development by actually enhancing or promoting maternal child attachment. So amidst the crisis in the home and environment of a child with NAS, what is child development like? Well, the sad thing is, if even if we want to promote attachment sometimes, um, we look at what happens to these mothers. And the rate of maternal deaths in Kentucky from 2013 to 2018 is really high, and it's going up. So if you look at the all deaths related, all maternal deaths within the first year of delivery, we can see that it is increasing in Kentucky to a rate of 140 per 100,000 births. If we look at the deaths of these moms related to pregnancy, it is also quite high to 74 per 100,000 live births. But some of these mothers also die of overdose. In fact, a large number of these mothers die of drug overdose. And you can see that the rate is 57.5 per 100,000 births. So how are we going to really promote that attachment between the child and the mother, which really brings us to the prevention effort of having these mothers seek treatment, and so that they could be ready to um, be attached to their infant especially when the infant is born. So at the same time, these babies, we give them their appointment to their pediatrician, but look at the number of well child visits and ER visits among children with NAS cases. In the dark blue bars represent the number of well child visits in the first year of life, and it shows you that less than half of these babies have adequate number of well child visits compared to the teal colored bars, which is the HEDIS measure for those children enrolled in Medicaid. At the same time, if you look at the gray bars, which is the ER visits, over half of these children have at least one ER visit in the first year of life, and 1 out of 7 will have 3 or more ER visits in the first year of life. So we really don't have very healthy children in the first year of life if they are born with neonatal abstinence syndrome. Now, how about the outcomes of those at babies with NAS at during the first few years of life? This just shows you that they lag behind when it comes to the MDI, or mental developmental index, and also their IQ from the Stanford Binet. Those are the red bars. And then in their motor assessment and in their language assessment. In the University of Kentucky, we follow up babies who are treated for NAS. And what we found is that this is over 100 babies that we have followed. And what we found is that their cognitive scores drop on the second year of life, and so is their language scores. If these children are followed to 13 years of age, this slide basically shows that the cognitive outcomes of these children are actually not as good compared to children without opiate exposure. Notice that these kids have, even at 13 years of age, they have a score of 83 compared to their controls of 88 with no opioid exposure. And similarly, behavior outcomes, these are total problems through 15 years. And the top line are actually the total problem scores of babies exposed to opioids, and the blue line are lower scores of those children who are their controls with no opioid exposure. Now the question is, can we change outcomes? It's so depressing to see all these associated risk factors. Well, we'll go back to our framework of the socio-ecological model. So we know the risk, which is at the bottom of these slides. There are plenty of them. But we have to look at the protective factors, as I mentioned earlier. And outside the family, when this child is growing, they need friends, they need safe streets and playgrounds, they need extracurricular activities, they have to have access to resources, community, school activities, and then we have to have community engagement. And then we have to have policies that would address community needs, ongoing surveillance of the needs of the community and problems in the community. Then we have to provide services that are culturally competent. Of course, funding needs to be available, and we have buy-in from stakeholders, and there should be available treatment centers, especially for mothers. And mothers who are treated during pregnancy and after pregnancy, they can have relapse. That can happen. Same thing as we don't have always full control of diabetes if we are a diabetic. So we really need to have available treatment centers that they can access. So when we look at risk and protective factors in a study called the maternal lifestyle study, we look at risk and we look at the balance with the protective factors. So we have the individual, the family, and the community risk and protective factors. So we were interested primarily with if there is a high risk but also a high protective factors or protective index, will the child do better? So we look at the total behavioral problems, and the top line here shows that from 5 to 15 years, these are the children with high risk and low protective factors. Look at their scores get worse over time. But the next line below that are the children with high risk but high protective factors. And look how the line goes down over time from the time they're 5 years of age to 15 years of age. And then if they have low risk to begin with, but low protective factors, you have also a flat line. There's no change. But even if they have low risk but high protective factors, look at the line going down. That means their problems scores decrease over time, so the behaviors improve over time. So this illustrates the importance of enhancing protective factors in order to mitigate risk associated with children exposed to opioids or other substances. So we can change child outcomes. We just have to direct our attention to protective factors that can balance the other risks associated with prenatal drug exposure. So the risks versus protective factors really comprise a continuum before birth and throughout lifetime. Remember your life course perspective. We have to recognize and prevent risk from early in life. We have to enhance protective factors to mitigate risk. We have to build resilience. And resilience is not just a characteristic, it is really a process. Resilience is the ability to overcome serious hardships. The foundation of resilience is the combination of supportive relationships, adaptive skill building, positive experiences that reinforce self-efficacy, perceived control, and belonging. Resilience requires relationships. That's why I keep on saying we need a strong and a wholesome maternal-child attachment in the beginning, and we need the family support in the continuum. The capabilities that underlie resistance can be strengthened at any age. So with it comes to an approach directed to enhance outcomes of babies or children with neonatal abstinence syndrome or those with neonatal opioid withdrawal syndrome. The approach has to be to the mother and the infant dyad or to the families and the infant together. The approach has to be multifaceted, coordinated, collaborative, and integrated. So when we see the mother at the time of pregnancy, we have to promote or tie her in to treatment. And if she did not have prenatal care and we see the baby in the hospital, well, we have to manage the NAS. We have to also refer the mother to treatment. And if she is already in treatment, we have to continue with her treatment. Then we have to do our discharge planning, our education on safe sleep, and prevent abusive head trauma. And then with that, when the baby is discharged, the baby goes to well child checkups, immunization for growth, and then we monitor ER visits, rehospitalization, but most importantly, we have to utilize the local health department, community services, HANDS, the WIC, family planning, the mental health centers. These parents need peer support, and we have to work with the Department of Community-Based Services. They are not our enemies. They are helping us promote the well-being of children, especially those that are at highest risk. And then in the community, they're going to need tangible services, housing, transportation, legal help, and other community resources. So we turn around and we say, well, we need all these wrap-around services. But wrap-around services for me is saying, oh, I refer them to this and I refer them to that. The mother is there and the mother is receiving this. But who really owns the welfare and the services for both the mother and the child, or the families and the child? So we really have coordination of care, mothers, babies, families, and babies, and integration of those services. The left hand has to know what the right hand is doing, because otherwise, in spite of all these services that they have around them, these children and these families are going to be lost in our system. So to summarize, exposure to adverse childhood experiences, violence, trauma, is the single most prevalent risk factor for children today. Adversity is necessary for life and learning. However, severe, prolonged, and repetitive adverse experiences are toxic, and toxic stress disrupts life and learning. Relationships are necessary for resilience. We have to build resilience. The lifelong toll of unaddressed adverse childhood experiences is a major cause of death and disability in adults. Knowing what we know now, we can do better in preventing, mitigating, and treating toxic stress. Adverse childhood experiences are not destiny, and early trauma does not have to dictate a life story. Research shows that protective factors, chiefly the presence of a nurturing adult, can cushion the impact of adversity in a child's life. As my late colleague wrote in 1993, some children thrive happily, others languish sadly. Are they not all ours? And from Dr. Andrews in 1964, The Children's Bill of Rights. The level of civilization attained by any society will be determined by the attention it has paid to the welfare of its children. Thank you, and I hope everyone is having a good day and everyone is prepared to look into the prevention of prevention of not only NAS but the prevention and mitigation of risk associated with neonatal abstinence syndrome or neonatal opioid withdrawal syndrome. Thank you.